Hey everyone, welcome to the Psych to Practice podcast, your one stop for practical and useful clinical information, masterful insights from experts in the field, and a guide to daily living. I'm your host, Ray Christner, and with me,
Paul Wagner.
Paul, again, back to doing another practice in action episode today.
And, this is a topic that we had, I think, pretty early on, we had thrown it out along with a lot of different ideas. But as we're looking and, we've mentioned before, thinking about, changing some of the structure, trying to make it feel functional. And, this is something that I think clinicians are, they're exposed to quite a bit, but I don't know that it's necessarily something that we get a ton of training on. It's kind of like, hey, you should just intuitively start doing this. Or if we do, it's, among like an onboarding process. And I don't know that we really kind of go in depth on it. And so we're talking about mental status examination or MSE. And so, on your electronic health records, there might be a tab or there might be a section, maybe it's a Dropbox or a narrative, but, it's pretty common, I think. And I don't know that there's a ton of information or conversations that are happening about it.
Yeah, I agree. It's really actually interesting because as I was kind of, we were preparing for this, I started just looking through and going, what trainings are out there in it. And it really is something we all do, but really, like you said, other than maybe a class that you had in college or maybe something you talked to a supervisor about, I'm not sure it's something we've really gone into a lot of depth in training. And, for me, I think I was lucky because I had several supervisors who felt very strongly about how we do mental status exams, why we do them. And I think it's really kind of made my clinical skills so much better. And so I think it's an important thing. I think it's probably one of, that and the clinical interview, probably the most important things we do to gather information when we're working with people.
And so much of it, I do think it's really the value is we're doing it without maybe even recognizing that we're doing it a lot of the time. Like, just by sitting and being present with, a client, we're examining these things. It's just, are we recognizing that we're doing it in this way? And, even as we were preparing for this, I'm going through and I'm kind of really trying to fine tune certain pieces of information. And I'm like, I've been using this term wrong, right? I've been, it's a checkbox. And I'm like, there's situations where that's maybe not quite the right box. And so adding that intentionality to it.
Yeah, and I agree. And, it's interesting because I think we confuse it. I think that's maybe why people don't talk about it a lot. So a lot of times, if you're talking to a physician and you say a mental status exam, it's kind of what they refer to when they're looking at somebody for dementia. So there's the mini mental status exam or the MOCA, the Montreal Cognitive Assessment. So those are mental status exams, but we're really looking at cognitive impairment in those. And that's part of, I think, all true mental status exams. But from a clinical perspective, again, it's part of our clinical interview, but it really is, what's the structure of data that we're looking at from observations and how people respond, and even things as far as how they walk. I mean, all of those things can have some, at least in our initial time with them, can be very diagnostic and can really help us understand. After we get that, we kind of pare it down a little bit. And I think, you mentioned the electronic health records, and in those EHRs, it might only be a few things that we're doing every single time that we're working with someone, but we always have that option to go back and revisit a longer version of it. So yeah, I think a very powerful tool, just maybe a misunderstood tool.
Well, and actually, so I know that you shared that you've updated some things since then, but one of the tools that I was referencing for this is it's a kind of a trifold of information here. It's a fundamental guide to conducting a mental status examination. Dr. Ray Krishner and Billy Hollander. And, I know we were just kind of like checking in. And so if you're interested, it I think is still a valuable resource. And certainly I think you mentioned it's still available on Amazon. So
it is, yeah.
If you're looking for something, physical to have in the office, it might be something nice to just kind of add in. It's, it doesn't take up much room. You can kind of slide it in and out where you need it. But, especially if there's needing a refresher beyond this episode, I certainly recommend checking it out.
Yeah, it's interesting that all came out of a presentation. So Julia and I were at doing a presentation at a conference, and I made a comment about mental status exams. And at that conference, it was actually a school psychologist who raised their hand and went, "I have no clue what you're talking about. Like, I'm not sure. I don't know what that means."
Yeah.
And so we spent some time talking about, really what it was. And it was interesting. The company that actually publishes that pamphlet, it came up afterward and went, that would be great to have something simple, because maybe we don't need a whole book on it, but something to just give people refreshers on what to do. So, I got to give a call out to Julia Hollinger, who was great with working on that. And, she's really more of the creative end of this. It's I think what made it kind of unique is, I'm a person who needs ways to remember things. So as we kind of developed it, we came up with kind of our acronym to look at what are the things that we collect as part of a mental status exam. And so we call it the ABCSMARTPICKLE Model. So, the crazier it is, I think maybe the easier we remember it. So,
absolutely.
So that became kind of how that actually developed. And you mentioned, I really right now, and maybe we'll talk about this as we kind of go through, have really been working on this mental status work a lot, and mainly around how do we change the language around it. I think, and as we talk through some of these categories, I think things that people will notice is we use words that just aren't always nice. And there are better ways to say things that I think we should be much more aware of now. I think we talk words matter, and words matter. And I think as we evolve as a profession, we can say things in a way that are much more supportive of those that we work with and still describe the behaviors that we're concerned about. And so, that pamphlet, I really want to redo the whole thing, because I think we need to really change the language in it. And we use language that's kind of been historical. And so, we can talk about maybe how we reword things as we're going through this.
Well, and, you threw it out there, and I think, for our audience, you mind kind of going over like ABCSMARTPICKLE? What is that?
Yeah, right. So essentially, it's just the first letters of the things that we're going to be looking for. So, we'll kind of run through and maybe we can talk about them in details. But, so A is for appearance, B for behavior. So kind of how they're reacting in the situation. C, the connection or social interaction we have. The S is speech and language. M is motor skills. A is for affect and mood. R is for risk. T for thought processes. P for perceptual disturbance. I for insight and judgment. C for concentration and attention. K for knowledge and memory. L for level of consciousness, and E for effort and cooperation. So I think I got them all. But so again, it's just a way that, when I'm sitting with someone for a clinical interview, I want to spend my time really kind of attending to them and having a conversation. And, one of the reasons I love acronyms like this is it lets me in my head kind of go through and go, okay, did I hit all these things?
Well, and the way that, and we were talking a little bit about this before we hit record, but like really the way that the MSE flows, it seems like there's, in part this kind of more objective, observable data. And then there's this subjective piece. And so, as you're going through, parts of this very much are an objective observation. And so, I think your example, as we were talking about this, was like, someone's gait, so when we're recognizing that, we're just taking in that data, and
Right.
how we're functionally using it, that might change later on, but that's just the information that's coming in. But then, we have pieces of like, mood, or overall like thoughts and perceptions, like those different pieces where it becomes a bit more interpretive. Like it's how we're understanding and viewing these pieces, and or been kind of talking about some of the terms. And I think a lot of times that's where the terms, I noticed the most terms on our MSE here with our
Right.
so many acronyms, helpful and confusing at the same time.
That's
But so I view those, and there's a hesitation there. And so, so I think that there's certain areas where certainly feeling more confident, in other areas where is this a fit? Is it not? But I think it's really making sure that we're understanding like what are we viewing? And as you said, like kind of more the narrative behind it rather than finding the right term to describe it.
Right. Yeah, no, I agree. And it's interesting. I think that, I find when I do workshops and we're talking about assessments, how many people really don't understand some of the words that we use. And I mean, I don't, that's not to be critical necessarily, but I think sometimes we just overcomplicate things. And I just did a presentation about assessment the other day, and I said, an easy example is the word ambulate. Like we'll say they ambulate independently. And I'm like, why not just say they walked? Why do we choose the words that we do when we're describing things? And, and we can kind of get into some of these details, but, like the word tangential, like, okay, I know what tangential means, but, my views changed over time that I think we should start using words that if a patient or a client looks at their notes, it makes sense to them.
Yeah.
And it's so tangential not going to make sense to a lot of people, but to say, they started talking about something and then change topics quickly, that makes sense. So I think there's ways that we can kind of use these kind of categories and I think reframe them a little bit. And, I'm somebody, if somebody wants to see what their notes are, I'm more than happy for people to do that. That's kind of how I try to write them. But it's, even like, I guess maybe let's even start with appearance. I've read reports where it's like somebody has poor hygiene or, they have physical abnormalities or words that just, reading those could come across wrong. And I don't think we should sugarcoat that. I don't think we should get away from it, but I think we can word it in a way to say, the person needs improved self-care is a better way to say than poor hygiene. And to say that they have distinct features such as, and to describe what those features are, I think is better than to say somebody has a physical abnormality. But, it's interesting because as simple as that sounds, most of the things that you see, programs and things, that's not the language they use. They will have poor hygiene or they're disheveled or whatever it might be. And again, I think we can say the same thing in a more supportive, appropriate way.
Yeah. So what if we just kind of go down and break things down and talk about some of these different sections? Some of them we might linger a little longer on. Some of them, maybe we can just kind of talk about what it is and don't necessarily need to go more in depth in that. But I guess if we're thinking about that, ABC Smart Pickle, the appearance, like I know when I'm first, working with someone, taking in we are talking about, how are they, functionally moving? Like, what is their overall presentation? Is it like the idea of being well groomed, proper hygiene, those pieces, and thinking about it now in maybe a different context, but at least in terms of the assessment piece of what are we seeing? What are we visualizing? I think a part of that can be okay, hey, is someone coming in and they are, they're well dressed for, a therapy session, or, am I catching someone and they are, shirts disheveled or stained or wrinkly? And I think also context is important. So if I'm working with someone, they're coming, I actually work with quite a few individuals coming off a construction job and, coming in their lunch or something like that. Okay. Hey, that's their appearance. but there's context that informs what that means. But I guess like that's kind of the way I view that idea.
Yeah,
Parents, like, what are your thoughts?
I agree. I mean, I think that we have to always have context as part of it. And, and I think that appearance, there's a lot of diagnostic aspects to that. Somebody who comes in wearing a suit, but they are unemployed is just as kind of, maybe eyebrow raising to go, why did they feel they needed to do this, as somebody who comes in who maybe does have poor hygiene, or maybe someone comes in and they're well groomed. Maybe they, casual, everything's no concerns, but then they may report, well, I don't shower for 5 or 6 days. That observation compared to that data is useful. I mean, I look at it as, I would have a follow-up question in that case. I would say, wow, you did really great today. So how did you do it today? Like, I'm curious about that. So, I mean, I think this isn't just diagnostic. It's just good information gathering. And to say, gosh, I appreciate that you thought about that coming in. And, and I'm curious what made you do that? And how did you get out of bed to do it? And I think we have a lot of follow-up questions. And as something as simple as an appearance, or if somebody has, tattoos or piercings, again, not in a negative way, but could be curious about them. I had a gentleman just actually not too long ago who works in a professional career and had some, I would say, negative wording tattooed on his hands. And so it prompted me to say, hey, I'm just curious. Like, I noticed that on your fingers. I noticed a few words. Can you tell me the story behind that? And it really opened him up to just, tell me about just a really difficult past as a young kid, and said, I chose not to take these off. Like, I thought about getting them removed because now I'm, father, I'm working in a profession, but it's my way not to forget what happened. And it became such a powerful story, simple observation. So, appearance can be really, I think, beneficial to look at.
And one other piece with that, I think we need to be mindful of as clinicians is telehealth. And so I don't think we get,
that's a good point.
Like the idea of having an appointment where we're going in person compared to, there's some like, early mornings, I'll meet with someone and they maybe haven't had much time since they've woken up.
Sure.
And so, they might still be in their pajamas and like, okay, like that's important information. And so again, with context. And so is it, 1 o'clock in the afternoon and, we're just, still in our pajamas. I go, okay, that's clinically significant. We're going to be following up on that versus, there's some kiddos where it's like, might be like, hey, we're doing a telehealth session and, something came up. Can we switch over? And it's the evening. They're getting ready for bed. So it's like, okay, contextually that aligns like that, so again, all of this, it's data, it's how we're also interpreting it, but we're not like interpreting it without necessarily putting a judgment. And I think like you asking about the tattoos, like if we can approach it with that curiosity, it allows us to have a better understanding. And that's really, I think what this is like. All of this is how do we have a better understanding of what's being presented to us? Right.
I agree. I think, and it doesn't, and that's why I think that kind of going back to the wording's important is that, if things like hygiene are a problem or there is an issue, it's fine. Like let's talk about it, but let's say it in a way that maybe is constructive to kind of help a person out. So,
and functional, like if someone's reading that, like, it's like, okay, yeah, no, I do need better self-care versus, like if I'm hearing poor hygiene, it's, it may be taking it as a ding to that self-confidence.
Yeah, agree. So let's kind of jump into the B then. So B, behavior. So for me, this is just kind of how they come in. Are they highly energetic? Are they coming in, they look fatigued or lethargic or, something like that? Is there an engagement that happens? Are they calm? All of those types of things I think we can kind of look at. So it's just, again, what is their behavior in that situation? And it can really be a range. I mean, there's a lot of ways we can look at behavior, but it's, again, kind of what are we seeing more than what they're telling us?
And, along those lines, like thinking about, I guess I keep getting stuck on that, like how we're interpreting the behaviors that are being demonstrated. So, if someone is coming in and they're being, I guess, thinking of like, they're really withdrawn, or even maybe a bit more like, hey, they don't necessarily want to be here, we're kind of shutting down. Like, okay, again, it's a nod to us to say, okay, is there more here? And, like the value of having that then recorded, that we can follow it up. And, we'll maybe talk there more towards the end, but the functional use of this, I think, it's a great progress monitoring tool too. And so if we're viewing it as someone's, more withdrawn or evasive or passive, and that's then changing as time goes on, like it's interesting to then note that and see like, okay, hey, what is this person like? How is this, how does the context inform these changes that I'm seeing here?
Yeah, I agree. I mean, and that's why we really should be documenting a lot of these things over time. And under behavior, I do want to kind of give a quick reference, because somebody came to mind as we were kind of talking. Again, kind of going back to this wording, I just read a report and was going over it actually with a family that came from a psychiatrist, and in the mental status exam, he wrote his behavior was agitated. And the kid, who's a teenager, was like, I was not angry during that evaluation. Like, I wasn't agitated. And I said, well, that's not what agitated means. Like, it means that you were like restless, like you were hyperactive. And he went, why does he say I'm agitated? That's like, he took it from an emotional kind of agitation, not a behavioral one. So again, this is where sometimes those words, people read them. And even the parents were like, oh, we thought he was like kind of maybe edgy with the doctor. And I said, no, I'm pretty sure he's talking about that it's more of a notable restlessness. He was fidgety. And they used the word agitated. But again, how simple words can kind of be confusing. Where just saying he was restless or fidgety or even hyperactive probably would have been a better term.
And so, maybe this next one, talking about connection. And, I think this is one where maybe starting to get a bit more subjective a bit. And so if we're recognizing like, okay, how are they doing in terms of if there's others in the room, if there's a kid there with their parent, like, are we, back and like, really unsettled if our parents are there? We really unsettled if our parents leave. And, I'm thinking of quite a few different clients of like, after our intake session and, usually a lot of times talking with parents, and then in our next sessions, like trying to then say, hey, like, do you feel comfortable with this? And really their response there is really informative. And it can kind of guide also how we're going to navigate this. So if there's a lot of discomfort with, hey, I don't feel okay being alone in here. Like I want someone else in here, even if they're just sitting quietly. Like I just want that secure base. Okay. Like again, noting that, circling back around, or maybe it's a conversation there and then, but so I think of that connection in terms of like social component too, of like, what's like, how are they interacting and engaging, or in the conversations that we're having, like, or context that's coming up, like, am I able to see that applying in other areas?
Yeah, I exactly. I mean, I think we can, this is a piece that we really added that's not really part of a lot of mental status exams, but that idea of connection, comes up all the time, and something, we thought was important in being able to just, again, person friendly. Are they different with parents, without parents? But, I think even some objective observations in the sense of their eye contact, like, I mean, it's something that, again, potentially could be diagnostic, maybe not, but something we could, could at least, think about and kind of go, oh, is this maybe a social anxiety? Could it be something, with autism or some other, kind of neurodivergence? There's a lot of pieces that can kind of go into play. So I'm one who I think, from the time somebody walks in, observations happen. And I even pay attention, how do they interact with our front office? That's a social connection, and that's helpful. If they don't say anything there, and really talkative in my office, and kind of makes me wonder. So, yeah, I guess a little bit of subjectivity and objectivity in that piece.
And not mistake, the next one being speech.
Yeah.
And so when I'm thinking of this, I'm thinking of like a lot of times like the tone and the rate that comes to mind. And so if but I guess also like with that tone, like the affect behind it. And so, am I being very like monotone? And so does it feel very flat? Does it feel very verbose? And like almost like, it's vocal regulation is, well, I work with a lot of kiddos like with ADHD. And so vocal regulation is something we work on quite a bit.
Right.
Yeah. And so all of those different pieces, I think, come into this like speech, and like those are some of the pieces that I look at in terms of tone and rate. But are there any other pieces for you, Ray, that?
Yeah, I mean, I think those are all great. I also, with kids, listen for articulation. I think things like word finding problems, maybe echolalia. I just had an interview this week that the person I was talking to, he repeated every question I said as an adult, and just was, and again, was just kind of a note, and I just was like, okay, it could be anxiety, and then I eventually went back and just, I've noticed this, like, and he's like, oh yeah, he's like, I have to hear myself say it before I can actually understand it. That was important for me. It made me kind of go like, oh, maybe we need to, look at the language aspects. And super, intelligent person, just really, it was just something he went into, and it looked like it was a habit kind of thing. But then as he explained it, and we got to test it out a little bit. I said, I want you to answer without doing that. Like, what's that? And he could do it, but he struggled with the answer, but much harder for him.
And again, like just the value of this, whether or not we're doing it, in a very rigid way, or if it's very conversational, but to take note of those pieces, because something that flies under the radar, we maybe miss, and it maybe, it influences treatment further down the line. And, right. I think this will be something that we really talk about, maybe even a bit more, but the significance of not assuming. And so, especially in these early interactions, curious about everything, let's ask follow-up questions. And, I'll talk actually with a lot of clients about things of like, how do we cultivate curiosity? But I think, we as clinicians also, we have to cultivate our own curiosity, and like digging a little bit deeper and saying like, hey, why are we repeating ourselves? And I feel like there's, thinking back early on in my career, that almost felt intimidating sometimes to like ask and approach. But if someone's here and seeking treatment and support, these are valuable things. And, something that maybe like, if it hadn't been mentioned, maybe we're not really recognizing, okay, hey, this is actually to help process and functionally understand, rather than, just a note taking or an anxiety. Like it, yeah.
Somebody could have written down that this gentleman was echoic.
Yeah.
They could have said that, because essentially it probably met that definition, but he's not in the context that word is supposed to be used. And it was, so yeah, I mean, I we hear this idea of curiosity all the time. We've had it a couple of times in the show, which I think's, great, but I'm going to add the other C to this thing. I think it's collaborative. What I find is when I make an observation, I go back and say, hey, I just want you to know, I noticed this. Like, I'd love if you could help me understand it, like what's happening. I actually have not had people offended. In fact, almost the opposite. They're so appreciative of not making a judgment, and to just kind of have a conversation with them. And it makes the whole clinical interview process go so smooth, and it becomes such a conversation. And I always love when people leave and they go, oh my gosh, this was great. It was like a great conversation. I still got all the boxes checked that I needed to do, but we can do it in a way that, lets people really tell their story. And I think it's so important, and, sometimes overlooked. And sometimes things in my head with a simple question, I go, I could have went in the wrong direction, with that. That's so, yeah, I mean, I think, that curiosity and collaboration in this whole idea of mental status will give us a much more clinically rich picture and a better plan with it, how to move forward with something.
And just, I'm going to see if I can build on the alliteration here. Like, I think clarification as well.
Yeah.
And, I do think all individuals, we have our preconceived notions and, we can do the best that we can to try to strip them. But if we can clarify, and so I think a part of that curiosity is explorative, but also ensuring that what we're hearing is actually, what's intended. And, I'll talk at length in terms of communication as, hey, our role as listeners is to shift and change our interpretation to match what's intended. It's up to the speaker to change how they're communicating, not what they're communicating. And we'll kind of go back and forth with that. But we as clinicians, we're listeners. We have to be changing what we're interpreting until it matches the intention. And that clarification piece, I think, is another tool that we can use.
Yeah, absolutely. So let's kind of move into maybe the next observational thing, and that's motor skills. So we hit on that a little bit about kind of, how somebody walks and things like that. But, I look at it as things like, are there tremors? Are there tics? Are there those types of things? So from how they walk to, am I just seeing certain movements, all kind of falls in that realm of motor development.
And I guess one other piece that I tend to look at is like hyperactivity as well. And so, and I guess also, borrowing from the psychiatrist, like agitation, but, more so the fidgeting piece of that, of like, and just trying to recognize some of those patterns of movement. And maybe it's something that we're questioning and we're exploring. Actually, after all the C's we were talking about, probably we should follow up on that to just ensure that it's accurate and that we have a clear picture there. But no, I do think that one is housed a bit more objectively and observable.
Yeah, absolutely, a little bit more observable data, but yeah, I mean, there's a lot of important things that can come from it. Noticing those little pieces and. Some of it we may observe and we may never use. It might just be a one-time thing, but there's other things that, again, using tics as an example, you see something, I don't know if I just note it at first, but after a few sessions that we see it continually happening, you gotta, kind of maybe look deeper. So,
and what's interesting, like when exploring, like especially noticing tics, it's interesting the conversation that sparks where, then the parents or the individual themselves starts talking about like, like I'm trying a trial run of stimulant medication and I'm noticing an uptick in, okay, hey, well, all of a sudden now this is, this is now, one, the medication piece, but also, is this then something that's noted that we're needing to then follow up? Or is this something that's, as a response to the stimulant, we're needing to then, kind of make a more informed decision of, does the benefits that we're getting from this outweigh the, maybe the social influences? And if it's something that's pretty innocuous, like, okay, but, making that a talking point, because if it's something that they're not, we're not verbalizing, we're just still in the dark.
Yeah, absolutely. So the A coming next is, I think, maybe an easier one for people, and that's affect and mood. So kind of both of those together. And I think sometimes those terms get confused a little bit, like what is affect and what is mood? So, mood is what people report. Affect is what it looks like. So again, kind of some direct, objective, I'm feeling happy, I'm feeling sad, versus how that, how does that present? So somebody says they're happy and, their affect doesn't have much emotion to it, or what we'd call like that. Notable. Or if somebody says they're sad and they're laughing throughout the session, also notable. And again, may not mean anything. Maybe the person's just nervous or whatever, but again, just good observations.
And, that's one where I think noting patterns, all of them again, but, this one in particular, noting patterns and trends really can inform diagnostics. And I think it's an area that think of therapy. I do think we tend to think of like mood, affect, is that emotional component that comes in, and being able to say, like, see, like, hey, are we trending? Like, both the report and our mood and our affect. How are we trending with that? And, is it pretty consistent? What does that tell us? Is it really, really variable? And, or, labile, all of it just all over. Okay. Hey, what does that tell us?
Yeah.
And so, a piece for clinicians to watch out for, because if we can recognize this, it just becomes a talking point to see, like, hey, we're in here maybe working on this, but consistently this is presentation. Are these related? Are there other pieces that aren't going on? And I'm thinking of times when noting certain topics that we'll talk about, and all of a sudden now there's this disclosure of, this is reminding me of this event that happened in my early childhood, or something along those lines, where, and if not asking, maybe I would have bulldozed and triggered some of those trauma responses. Or again, it's like, oh, hey, this is something that maybe wasn't reported even initially at all. And so our ability to tend to that, I think, is invaluable.
Yeah, absolutely. And I think kind of the next category, moving on, the R, kind of comes off of some of this mood stuff, and that's related to risk. So, we, not uncommon for things like suicidal and homicidal thoughts being part of any diagnostic interview or mental status we're doing. We kind of reframed it into the risk category, because I just think there's so much more that we should be looking at, So, I mean, of course, hey, we want to look at suicidal thoughts, or, any self-harm or harm to other people. But also, things that can fall into that can be things like cutting, could be a part. Maybe a risk factor is related to excessive technology use. Maybe it's related to, also drinking. There's a lot of things that kind of fall into that.
I had one recently. He's like, I almost ran away from home. Oh, okay. Well, what happened and why didn't you? But I mean, and that's a risk. And, it's never been something that has been reported before, either from, client or parent. But okay, hey, that's something that we now need to be aware of. And even if it's just I'm venting, some of these frustrations, and, I wanted to run away, but I didn't want to. Like, okay, so we're having those thoughts, like, what would have had to change for us to be there? And like that explorative conversation. Again, the conversation surrounding suicide, risk in general, I think tend to make individuals uncomfortable. So they try to skip past it. Oh, no, I wouldn't do it. Well, hold on, brought it up. Why? Where are we at? And I like normalizing those conversations, and saying, like, hey, how do we have a better understanding and feeling more confident and comfortable engaging in this, rather than it being something we try to keep hidden away, because that is not a value to anyone if we're just trying to lock it away. Yeah, I agree. And I like the example you had about somebody running away, because I do, again, I think that's definitely a risk kind of thing we should keep in mind. And, similar to what we hear with self-harm and harm to others, with anything risk-wise, I always kind of go, are we in a thought phase of this? Are we in an intent phase? Are we in a plan phase? Are we in an action phase? And kind of thinking of it in that way. And, in the example you had about, somebody kind of just quickly, I'm not going to commit suicide. That's great. But tell me about the thoughts that you have around that. And I think in some ways, even normalizing for people that, listen, it's okay. Like, if you have thoughts, it's okay. Let's talk about those. Yeah. Doesn't mean we're going to go put you in the hospital. Doesn't mean, all of these things that we have with that, but it helps understand, that's just a sign that you're really in a place right now that's not a comfortable place for you. And let's have dialogue around it. And I think, this is somewhat related. The value of really covering confidentiality in our early sessions, and, every single person, even if they're a transfer client, I'm like, hey, I'm going to go over my spiel about this, right. But it's talking about, what are the times that I can break confidentiality? And I bring up, suicidal ideation, homicidal ideation. but really going down and breaking it down and saying like, these are the points. And even then this isn't me saying, don't tell me about this. This is me saying like, hey, this is our response when this gets to this point. But let's talk about all the other pieces. So I cover, I'm like, hey, if you tell me that I've been thinking about ending things, like I don't feel like being here anymore. Okay. Like that's not having me then, break confidentiality in 302. It's okay. This now becomes a topic that we can really work on. But I think individuals can come in primed to avoid those topics or trying to talk around them.
Sure.
And there's some individuals who, they're in that action, they've been in that action phase before. And, I can think of a handful that I've worked with that have been hospitalized, that they avoid these conversations, yet they're the ones that, like, those are the conversations we need to be having. And so I think us as clinicians doing our due diligence, normalize, to break down stigma and inform really like kind of what the threshold is, why that's the threshold, what comes before it, but also this isn't, don't hide it. Like, this is us for safety and support.
Yeah. And this is probably not a popular thing to say on a podcast where there's clinicians listening. I think as clinicians, we've caused the problem for people not to disclose because we react. So, we'll go back to those C's a little bit, right? It's asking is to be curious, and asking is to collaborate with them and really kind of find out. And I think if we approach those conversations better and we collaborate with, I don't, it's not comfortable that I hear that you say you're going to hurt yourself, but what can we do together to support you, stay safe? And we have a conversation that's not just about, I'm going to have to, have you see crisis. We're going to have, give people maybe a little preview here in just the next few episodes. One of people that I just think is brilliant, David Jobs, is going to be on talking about working with suicide and what's the research really say about what we should be doing. And what I love about his work is he breaks it down to really be collaborative with people and realize that us making it where they think they're going to go to the hospital causes more of a problem, and it doesn't necessarily result in better treatment.
No.
So how do we collaborate for safety? And I think it's an area we can continually get better at with individuals, and ultimately there's a time that some people we have to take steps, and ultimately it's keeping them safe. But sometimes we do it way too soon, and probably because maybe we're uncomfortable asking the questions. So I think maybe people don't want to talk about it, but I think even there are clinicians that don't want to get down into that intensity of doing it. But I have found many people who say, I've had thoughts. Once we kind of really go through it and understand it, it's not something that they're necessarily unsafe, but it definitely is an indicator of how distressed they are at the moment. So I think it's an area I'm excited about our upcoming episode, because I think it gives a different spin on this idea. So let's jump then to the T, which is thought processes and content. And I think this is the area where we put the most confusing language in.
I believe that this is actually I have a couple written down between. I have flight of ideas, tangential thinking, circumstantial thinking, loose association, thought blocking, and then thought insertion. Like, so all these different, and
right.
Some of that language, I remember early clinician Googling, I'm like, MSE, what does this mean?
Right.
And, even again, as I was reviewing, I was like, I use tangential a lot, but this is maybe a bit more of a flight of ideas. And, again, this is that checkbox piece. And I know what I'm seeing and interpreting, but making sure that it's being conveyed in a way that's, we can accurately go back. And thankfully, I'm at least consistent with it. So, having that going for me. But I think it's really how we're viewing the formation of thoughts and how they're relating to whether it's conversation and they're sharing a narrative, or even in their response, like the back and forth response of like, I ask a question and are we responding with something different? Am I trying to then, pull on to something, a bigger idea? And are we stuck in a certain thought and not able to move forward? Or, are there certain thoughts that we just won't hear? And it's like, I'll bring this up and it's, we then almost reactively shift and change those subjects. And so I think, it's an area that it deserves kind of taking the time to understand these different pieces, because, I'd be willing to bet that there's clinicians out there, and I know myself included, that we look at those terms and then we're like, I don't know, that's definitely not appropriate. But, upon further observation, it's like, no, this might actually be here. This might be occurring a bit more. And it's funny, we've been using the word tangential. And that's actually a term, again, as we were getting ready, I believe it was even like last week, I was kind of, I was reviewing over, and it's a word actually I've been bringing into the therapy office a little bit more, and talking and describing it and using it actually of like as a, hey, it feels like we're being tangential here, and like I'll get the look, and then like, but being able to make it a conversation and the recognition of like, oh yeah, no, that I am doing that. And so want to just give them a word that they can use.
That's right.
But so it's just, I think it's a valuable thing to really attend to.
Yeah, absolutely. And I think I think this is an area where we do best if we describe versus trying to find some clinical vocabulary.
Yeah.
For. I think that it's, and I don't think like words like tangential are necessarily that difficult, but for some it might be. But I think like things like, flight of ideas, know if everybody necessarily knows what that means. So, just saying, the individual has many ideas that come to their mind at one time, which makes conversation difficult. Very, very easy to understand that. And, I think even, the idea of loose associations, like what does that mean? Trying to get better wording around what we're seeing, I think, definitely helps. And I think in this, we also, not only those type of thoughts, but even paying attention to, obsessions. Phobias are a thought process. There's certain things that they, that we can put in there that we're of note. Those are also, I think, useful.
And I guess jumping into the next topic of perception. And so, a lot of times when I'm viewing this, it's almost looking at, are there, and I'm going to use maybe the terms that, again, better to use like in more the narrative piece and explaining it, but like, are there hallucinations? Right. Are there any difficulties with certain like sensory components that are going on within the session? And so whether that's, certain individuals I work with that have like a visual impairment or an audio impairment, and others that, working with some individuals that there are some auditory hallucinations, olfactory hallucinations, so that different pieces that ensuring that we're asking about these pieces. And I guess kind of jumping into the next one, the I in Smart Pickle, I believe is the insight and judgment and kind of those two areas there. And, in that way, I find that there's certain diagnostic information that we can get that can be pretty objective. If, hey, we're making a lot of risky behaviors that we're not really kind of thinking through, like, okay, are we then not stopping and developing that insight? But other times, I find that this one can be a more challenging one to really kind of say like, okay, is this a lack of insight? Is this circumstantial? Is this, is it vary? Is it contextual? Like, so I guess for you, Ray, like when you're looking at that insight judgment aspect, like what are the pieces that you look for?
I think, I think what you said is important. I think before I say kind of the content, I would just say, that's why we do this continually.
Yeah.
It's because first impressions might be difficult and it's going to be hard to do. But, I kind of look at this as what is their actual awareness of how things are life. I'll use an example. I had a young guy that I just evaluated for a learning disability. And he's a junior in high school. He reads at a second grade level. And in our time together, he said, "Oh, it's not a problem. It's just my mom making a big deal about it." really good awareness. I mean, he super struggled. Now, is that he is aware and that's a defense mechanism? Maybe. But it's something that we at least need to go further with. So I think the awareness, and then what is their, I think even from a treatment standpoint, what's the judgments they make to help make improvements for themselves or obtain supports for themselves? I think that's another piece I kind of go through. So, is it something that they say, I'm on my device for 9 hours a day and they aren't willing to set it down while they eat dinner. Maybe that's a judgment issue. So I look at those kind of basic.
And I guess one thing that I can probably overthink quite a bit is, is this, one part, I think, culturally relevant, but thinking of an individual who there's some financial struggles, and yet we continue to open credit cards, and yet we continue to rack up debt, and there's lawsuits that are pending because of this. And it's like, okay, at first, where did this start off at? And then now is it becoming an avoidance and like pattern of behavior? But did it really start off as I wasn't aware that, how this system worked? And so certain things that I do think are more commonplace, like that's the cultural piece of like, now after purchasing a vehicle, like my identity theft, I think I mentioned, I'm much more aware of credit score and like I'm going well in depth on, on Equifax and Experian and all of those. But prior to that, I could have vaguely talked about it, but I really wouldn't have had that awareness. And so a part of it, I think, is our exposure. What are some of the cultural norm pieces? And if these individuals haven't had them, is it a lack of insight or is it a lack of exposure?
Sure. Yeah. I mean, I think that's a great one. Money is a really good example. I have a individual I've been working with who, is an adult that parents helped financially for a number of years, managed bank accounts and things, now has their own access and have credit card debt. And it happened really fast. And, the individual was like, oh my gosh, like, I can't believe it's happening. It wasn't for judgment. It was a learning piece for her.
Yeah.
So I think we have to think of the culture. We have to think of their experience in it. But some of it's clear cut. Sometimes if, we see people who are engaging in really risky behaviors, it might not take that much thought to go through it. So it really just depends. But so let's move into the C, concentration and attention. I actually think this is probably an easy one. Not too hard to do.
No, certainly. Again, like I think there is some maybe context dependent pieces, but for the most, like, are we able to attend? Are we able to, navigate and switch and kind of be congruent as we're going through the conversation? Or, are we checking our device or, are we, in the middle of it, like, picking something up and messing around and, needing it to be re-explained or, earlier on this week, I had an individual that we're kind of talking and, I'm trying to explain one thing and I just zoned out. Like you said something and I zoned out. Right. And it's like, okay, like, hey, like, so, sure. So like, yeah, I don't know that there's a ton there that, there's a lot of different options, but, are we able to attend and are we able to maintain that concentration? Is it varied? Is it, or, I don't know that there's a lot of different options. And I think we
even can lump like hyper focus in there as well.
Absolutely.
As another part where it's, it might be the other end of that kind of continuum, but something we kind of pay attention to. The next two, I think we could kind of lump together. So, knowledge and memory, and then level of consciousness and orientation. And these are the ones when I said earlier, we think of them as kind of this assessment for dementia, something that and these are really kind of those pieces. Still something I evaluate and kind of document for everybody, but, knowledge and memory, just, can they tell you their story? Do they remember details from their past? Are they struggling now with getting to do work tasks, those kinds of things, and may not be a cognitive deficit, but something to pay attention to. For me, from a conceptual standpoint, I also in this area like to talk about like lack of education. I have people who, some of their struggles are, they've had seventh or eighth grade education, and their understanding and knowledge is going to look very different than somebody who's has a law degree. And so we just need to kind of be aware of those things. And then the consciousness is just, again, that kind of awareness, or you alert to your environment and know where you're at, know who the people are that you interact with. And again, for many of the people that we're probably seeing in therapy, at least in an outpatient setting, that's probably not going to be come up, anything that doesn't, appear to be, kind of a typical reaction, but still worth looking at. So I still do ask people their address. I still ask them if they know their birthday. Again, part of that's an assessment. And part of it is just gathering some demographics as well, but it's a good way to.
And, I think that piece, the only other maybe part in terms of like the memory that I think I attend to is when talking about executive functioning, like the working memory components of that as well. And so like, how much are we able to like fully attend to at one given time? And, are we, are there errors, like, and how that fluctuates. And so I think it was Steve Shaw that we were talking with. And man, did that conversation stuck with me. And I think you used the example of whiteboards, and I have a different size of whiteboards. And like, it's just a great visual of how much information can I hold and cognitively and intuit and work with and adapt. And so I don't necessarily know that it was intended for working memory, but I think that's a part that I like to bring into that conversation.
Yeah. I mean, I think it's definitely a part that we can kind of look at. I mean, I think that's the beauty of these categories, right? It really is dependent. And for some people, working memory is absolutely going to be a part of the discussion, especially if we're working with, individuals that have, attention deficit concerns. Working memory could be difficult, or learning disabilities, whatever. So yeah, I think absolutely it fits there. And, as I told you, I'm kind of reworking some of my thoughts around this, I've been trying to figure out how to do the executive function piece in this. So when you brought it up, I was like, I've been trying to think like, how does that really fit in? Because that has been something that over time we see with so many other conditions. At one point it was just really connected to ADHD. And now we're seeing, different executive function profiles for anxiety versus depression. And, that functional impairment absolutely can be a part of many people that we see, and some just are dealing with life stressors. So, that one's going to be our revised version of this conversation. So
we think about judgment in terms of organization, prioritization, kind of aspects of that as well. So I think it's a part of the conversation. It's
a part of the conversation for sure. And, so we'll end with our E, and it's effort and cooperation. And, I think, again, kind of not a difficult one, is the person coming in, kind of ready to do this, putting forth a good effort, and maybe they're not. And I think, probably most of the people that I see for therapy that come in, maybe not quite cooperative yet, or maybe children and adolescents who, they were told they're coming to therapy initially, and maybe they haven't bought into it yet. So, again, just something to kind of what's their level. And I almost look at this in the sense of kind of a readiness to change. Where I think that it kind of fits in, part of the effort might be that the person's just not there as far as ready to take action yet. So we can think about those, and again, get curious with the person to find out what's the cooperation issue about. And, again, ask further questions.
And we're talking about something that is, we can go really in depth, we can go really surface level, but I do think that we do a disservice if we don't attend to these pieces in the session. And, trying to think about like that functional use of this, I think it informs how well we're able to understand and connect. And so, there's the interview piece, but and, the interpretation that the MSE can give, and whether it's objective or subjective interpretations, it's just what's the lens that we as clinicians are experiencing what this individual is sharing with us.
Yeah.
And in doing so, we're kind of holding space for both and saying, how does that inform, how to offer support, how to offer, positive growth and change, but also compassion and understanding. And so, I think it's such an important piece. And I think if we do it well, it leaves someone feeling well heard, and they're walking out saying like, hey, I appreciate you taking the time to get to hear me. And talk about buy-in, like, if someone feeling heard and well understood, I think that is a catalyst for change.
Yeah, I mean, I think we'll never see a day in the field of mental health where the power of curiosity and observation aren't beneficial. I think that's what good mental status exams are. It keeps us curious. It keeps us be good observers. And it really does, kind of from progress monitoring to just maybe picking up on things that weren't said in context, but we can kind of then hear questions. An invaluable tool. So I'm glad we had a chance to talk about it. And, I know a lot of little details, but I do think there's importance to it.
And, people are complex. So, the
That's right.
mental status exam is going to be complex. And, so certainly hope you enjoyed this week's episode. Tune in 2 weeks when we're coming back, and, certainly excited to announce that we're going to have a conversation with Dr. David Jobs. So tune in for that. We'll make sure that we're posting on social media, but until then, make sure that you're an ABC Smart Pickle. Be well and stay psyched. The information contained in this podcast and on the Psych to Practice website is intended for informational and educational purposes only. Nothing in this podcast or on the website is intended to be a substitute for professional, psychological, psychiatric, educational, or medical advice, diagnosis, or treatment. Please note that no professional patient relationship is formed here, and similarly, no supervisory or consultative relationship is formed between the host, guests, and listeners of this podcast. If you need the qualified advice of a mental health professional or practitioner, please contact services in your area. Similarly, if you need supervision on clinical matters, please locate a supervisor with experience to fit your professional needs.